Good evening. Welcome to all the academically oriented practitioners present here. Today is World Vegetarian Day. We are stuck with nutrition and infection. In our third world countries, four most common pathogens were E. coli, Shigella, Cryptosporidium, and rotavirus. Today, for our journal journey, we have chosen topics of social pediatrics, that is rotavirus diarrhea and anemia mukta Bharat. Let us get updated information about it from our enthusiastic presenters as well as experts. May I invite Raigad IIP star member, Dr. Neha Singh, for formal welcome of the dignitaries. Over to you, Dr. Neha.
Thank you, Chitra ma'am. Good evening, everyone. And on behalf of Maharashtra IIP as well as Raigad IIP, I, Dr. Neha Singh, welcome you all for today's journal journey. In absentia, I welcome Maha IIP President Dr. Ram Gopal Chezara, Secretary General Dr. Amol Pawar, Maha IIP Coordinator Dr. Saifi Sahane, as well as all the respected executive board members. I also welcome Raigad IIP President Dr. Vikas More, Secretary Dr. Ajay Kohli, respected Dr. Niman Mohanty sir, past President Maha IP Dr. Hemant Gangulia sir, and all the members from Raigad IP as well as other branches. I also welcome our esteemed experts of today, Dr. Sagar Kulkarni and Dr. Ajay Keshwani sir, as well as our presenters, Dr. Pramod Wankade and Dr. Mamta Khandele. Today, Dr. Chitra Kulkarni, President AHA Raigad, and myself, both of us will be moderating this session. And we request attendees to please post your queries in the chat box. We will be taking them at the end of both the articles. So now I invite Raigad IIP President Dr. Vikas More sir to please say a few words. Over to you, sir.
Thank you, Dr. Neha. And on behalf of IIP Raigad, I welcome all of you. This is a consistent journal journey due to the blessings of our dear Niman Mohanty sir and our flawless team of Chitra Kulkarni Madam and Dr. Neha. With the blessing of Gangulia sir and of and Amol Pawar and Dr. Satish Sahani. So we know that medicine is an ever-changing science. There are many things which come on and go on. So we need to get updated. But many times we feel that reading a journal or reading a case paper is a responsibility of a PG student, not a practicing pediatrician. So now the Maharashtra or the Western India also getting this culture of even a practicing pediatrician are getting this culture of reading the case paper. The classic example is Dr. Pramod Wankade sir. Even at the age of 60, I'm revealing his age, but he is so enthusiastic that he just called me a few months back that he want to present a case paper. So this shows the kind of enthusiasm is being generated all over Maharashtra. Many people want to present the case. We are getting thoughts. And one very emotional and nostalgic presence is of Dr. Ajay Keshwani. He still not joined. He is my teacher from Yavatmal. So sir is very close to me. I have done my MD from Yavatmal, so I have a emotional connection with Yavatmal. Dr. Mamta might not be knowing that. So I have spent 3 years of my life in Yavatmal. So talking with Yavatmal from Navi Mumbai is again an emotional moment for me. I am thankful to Dr. Sagar Kulkarni from Sambhajinagar for being an expert for today's webinar. And more importantly, I am so happy to be a part of this valuable journey because we know that the science, we feel that no knowledge is a axiomatic truth. That is, nothing is infallible. Infallible means which is without mistakes. So we are bound to do the mistakes. So we are craving for a journey towards the infallible truth through the webinars like this. I congratulate whole members for executing consistently. I am so fortunate to be a member of this wonderful team. Thank you so much. Over to you, Dr. Neha.
Thank you so much, Vikas sir. I also acknowledge the presence of Dr. Anjali Kokand, ma'am, and Dr. Amol Pawar sir. Kindly unmute and give your blessing, sir.
Amol sir, good
Thank
evening.
you. Thank you. Good evening, all. Good evening, Dr. Hemant Gangolia, sir, past president of Maharashtra IP, Dr. Chitra Kulkarni, ma'am, Dr. Jay Pandarkar, sir, Dr. dear friend, Dr. Pramod Wankhede, sir, Neha, Vikas, sir, Dr. Sagar Kulkarni, sir. Good evening, everyone. And this is a very nice journey of journal journey with Raigad IIP team and Maharashtra IIP collaborated since last more than 2.5 years. Once Dr. Hemant Gangolia took over, we initiated this journal journey. We clubbed it with Maharashtra IIP, and from that time till now, it has been a very flawless journey of Raigad IIP team with journal journey with Maharashtra IIP and all Maharashtra IIP members, even the national leaders, national office bearers, and national EB members also appreciated it. And this year we have taken with involved all the many of the other state members also. So congratulations to all the team members of Raigad IIP and Maharashtra IIP as well, and all the best to the all the best to the speakers involved in today's journal journey and experts also in Maharashtra IIP. Thank you.
Thank you, Amol sir. And now
Thank
I
you.
request past president Maha-IP Dr. Hemant Gangolia sir to give his blessings. Over to you, sir.
Good evening. Thanks, Dr. Neha. And day one of each month is an alarm bell for the journal episode since last 2.5 years. And good evening to each one and all. Respected Maha-IP office bearers, Dr. Amol sir is present here, others in absentia, as well as respected IIP office, Raigad IIP office bearers, Dr. Vikas More, and all the office bearers of IIP Raigad, as well as AHE President Dr. Chitra Kulkarni Madam. Today evening, actually they have just said, but the two moderators are the Dr. Chitra Kulkarni Madam. She is the AHA President IIP Raigad, as well as she is the strong pillar for the journal journey episodes along with Dr. Neha. She is the editor of the IIP Raigad, and she is the strong. These are the two strong pillars for the journal episodes. Dr. Nimen Mohanty sir, our mentor, he has not joined. And we are having really good two experts. Dr. Sagar Kulkarni, he is almost synonymous with vaccinology wizard. And the another one is Dr. Ajay Keshwani sir from Yavatmal. He's a very dynamic personality and he's a multifaceted and a very lively person. If you have enjoyed his company, he's a very lively person. So we had the opportunity to meet at Yavatmal. Today's presenters, we have very senior pediatrician from Raigad IIP, Dr. Wankhede sir, and he will be presenting one article. And another presenter is Dr. Mamta Madam from Yavatmal Medical College. And so today's episodes, probably we are having today we are having two interesting topics. One is that what is this? We want anemia Mukt Bharat in spite of having anemia across the country and in all ages. And is there anything beyond iron to think about anemia in below 19 years of age? And another topic is very interesting because once upon a time we used to have a diarrhea season. Now that over last 2 or 3 years it is decreasing. So whether we are moving towards this diarrhea Mukt Bharat also in the view of this rotavirus vaccines. So probably these two interesting articles are there, and we are very eager to listen on these two topics, two interesting articles from journal, a habit which we used to have during our PG days as a journal club. And so we'll hear from these two interesting articles from these two interesting personalities or presenters, and with expert comments from our experts. So all the best wishes, and I'm very sure that this today's session will be a very enlightening one and probably a learning one. Thank you very much.
Thank you, Gangolia sir, for all the blessings. We acknowledge the presence of President of Palghar Academy of Pediatrics, Dr. Jayashree Deshpande, ma'am. So friends, for today's session, we have two experts with us. Our expert for first topic will be Dr. Sagar Kulkarni. Pallavi, ma'am, please share the slides. Dr. Sagar Kulkarni sir is consultant pediatrician and director of Bhakti Children Hospital. Sir is also past secretary of IIP Aurangabad, scientific convener of National Vaccinology Module DIP from 2021-23, faculty at various state and national conferences as well as workshops, editor-in-chief and contributing author of Vaccinology Simplified Book and Adult Immunization in Office Practice. While an expert for second article is Dr. Ajay Keshwani, Professor and Head of Pediatrics Department at SBN Government Medical College, Yavatmal, Director of Keshwani Hospital, past President of AOP Yavatmal in 2022. Attended many international and national conferences as faculty, recently invited as faculty at Amsterdam, Netherlands. He has 9 international publications as original research articles as first author on various topics of perinatology. While our presenters for today are Dr. Pramod Wankhede, practicing pediatrician and director of Dr. Wankhede Hospital and Sri Datta Clinic, Khopoli, Raigad since 28 years. He is also past president IIP Raigad 2022. He will be presenting the review article Indirect Protection from Rotavirus Vaccines. While our second presenter is Dr. Mamta Khandale, worked as consultant pediatrician at Care Advanced Pediatric and Newborn Hospital, Nanded for 9 years and currently working at Sri Vasantrao Nayak Government Medical College, Yavatmal. She will be presenting the research article Need to Look Go Beyond Iron Supplementation for Anemia Mukt Bharat amongst children under 19 years. So now I request Dr. Wankhede sir to please share his slides.
Thank you, Neha. So my slides are visible?
Yes, sir. You have to go to the first slide.
Yeah.
Yes, sir. You can start the presentation.
Right. So good evening to all. Our respected Dr. Mohanty sir, our secretary, Maharashtra IIP, my friend Dr. Amol Pawar, our president, Dr. Vikas More, Secretary Ajay Kohli, Mangolia sir, my expert, Dr. Sagar Kulkarni, and another expert, Dr. Keshwani sir, and Neha madam, and main driver of this journey, Dr. Chitra Kulkarni ma'am. In fact, she ordered me to present this article and I have to follow it. So, and at the outset, I would like to thank to my home branch, Raigad IIP, for giving me opportunity to present this article. So, indirect protection from rotavirus, a systemic review. This article is taken from expert view of vaccines. This is a very prestigious journal. They have got impact factor of 5.5. The authors are Taylor Shivers, Jordan Cates, Eleanor Burnett, Umesh Parashar, Jacqueline Tete. These are all the division of viral diseases and disease control and protection. So one thing I would like to tell about this journal that this journal is a work of government of United States. The contributors, contributors has done his official duty of government of United States. That's why it is considered as US government's job. So, and another thing is I would like to highlight again that they have contributed from WHO and UNICEF also. So, a background of this article, the rotavirus vaccines have prevented substantial morbidity and mortality due to severe rotavirus gastroenteritis in children for nearly 2 decades. Since licensure, the studies have measured the direct protection of these vaccines primarily through clinical trials and observational studies that compare outcome between immunized and non-immunized individuals. The indirect protection, that is herd immunity, community immunity, population immunity, can be bolstered the overall impact of vaccination program by reducing cases, hospitalization, and death among the whole population. Both direct and indirect protection play a role in programmatic level vaccine decision-making process. Need to study. So, quantifying the indirect impact of rotavirus vaccination across the lifespan can improve the cost effectiveness, estimate use for vaccine decision making. Better understanding the indirect protection of rotavirus vaccines may also help us better understand rotavirus epidemiology in the post-vaccine era, including outbreaks and differences in performance by country. Understanding indirect protection of rotavirus vaccines will continue to be an important area of investigation. As a new rotavirus vaccines become widely used and as more countries introduce this vaccination into the routine immunization program. In fact, what happened, there is no standard approach for rotavirus indirect protection. So estimation of indirect protection are challenging to define and compare across settings as they require assumption of around transmission condition and population immunity, which are often poorly characterized. They do not have standardized measurement for indirect protection of rotavirus vaccination. So, what is it? Let me tell you what is the direct protection. The direct protection is stimulating the immune systems to recognize the offending organism before it can cause the diseases by developing specific antibody. And indirect protection is reduction in infection and diseases in a segment of unvaccinated population at the cost of proportionate vaccination of a population. When significant portion of population against the contagious disease, it arrests the transmission of viruses by developing the immunity in masses. So, this has cleared the doubts of direct and indirect protection. So, methods and material in this article, they used literature search strategy and inclusion criteria. They perform a literature review of article indexed in PubMed, Embas, CINAHL, Scopus databases. They use search terms, herd immunity, indirect protection, rotavirus vaccines like Rotatec, Rotarix, Rotavac, Rotacil from 1st January 2006 to 31st December 22. So this is a vast study of 16 years. So this is not a single study. There may be a chances of overlapping of the generalization of estimates and variations. So considering all these factors, we have to there is a scope for again further study in this field. So exclusion criteria they've adopted the review, presentation, non-primary research, and publication that did not include estimates specific to internationally licensed human viruses. So data abstracted and definitions. Data abstracted from article in Microsoft Excel. They defined indirect protection as any estimate of the change in rotavirus morbidity among the unvaccinated individual in the setting with rotavirus vaccine introduction compared to all individual in setting without rotavirus vaccine introduction. Rotavirus introduction means the indirect immunity protection starts after the introduction of the vaccines. So they include incidence rate ratio, the relative percent in proportion of acute gastroenteritis stool specimens positive for rotavirus or relative change in absolute number of positive rotavirus tests. So these are the three top type of metrics they use. the data abstraction on outcome described, that is hospitalization, nosocomial infection, community infection, or symptomatic infections. So analysis, they summarize the frequency and proportion of studies by following factor, that is World Health Organization given area, childhood mortality strata of the country of study, and group evaluated for indirect protection, that is age eligible, unvaccinated. They were eligible for the vaccination, but they were unvaccinated, and age ineligible, and in third, both. They categorize country into three child mortality strata. The country with low child mortality, country with medium child mortality, and country with high mortality strata. So they sorted a provided age group into 6 strata, that is infant less than 2 months, children less than 5 years, children more than 5 years, children and adults more than 5 years, and adults from 18 to 64 years, and adults more than 64 years. So analysis, the method of ascertaining rotavirus, that they involved ICD-9 and ICD-10 codes. And lab test, there are various lab tests like enzyme immune assay, polymerase chain reactions, PCR, PAGE, that is polyacrylamide gel electrophoresis, and immunochromatography, and other non-specific tests. The primary analysis summarize distribution of estimation of indirect protection against hospitalization due to rotavirus gastroenteritis among the unvaccinated children under 5 years. This was the majority of the of this group. The majority of the cases were for this outcome and age category. So determination of rotavirus status. Ascertaining the rotavirus status data came from hospital surveillance 44%, administrative data 32%, laboratory surveillance 19%, nationally notifiable case surveillance 3%, case control study 1%, cluster randomized trials 1%, ICD course 33%, ICD and laboratory method 3%, and solely laboratory method, that is highest 65% to determine the rotavirus status. See, this is not the active surveillance study. This is the abstracted retrospective study. So study selection and study characteristics. There were there were 2,293 articles identified and title reviewed. Out of that, they found 1,795 not relevant, so they excluded it. Then remaining 498, out of that 2,203, they found it insufficient or pre and post vaccine introduction data. The 125 in unvaccinated group and not included. So, and 95 alternate endpoint, that is all cases acute of gastroenteritis, they excluded it, and remaining 7 they found it duplicate. So out of that, they only studied 71 articles induced. So out of that 71 articles for study, there were 399 estimates of indirect protection from the rotavirus vaccines that could be abstracted, stratified by metric, outcome, age group, year since vaccine introduction. So study selection and study characterized. The median number of available estimates per study was 3. Majority of the studies, European region 42%, American region 23%, African region 17%, and low childhood mortality strata country, that is 68%. These are all regions given by WHO. The most studies from adult and child population, age eligible at the time of study, it is 87%. So study selection and study characteristics. So study selection and study characteristics, estimate characteristics. 36 studies provided data on 229 incidence rate ratio. 27 studies provided data on 88 estimate of relative percent change in rotavirus percent positivity. And 14 studies provided data on 82 estimates of relative percent change in number of rotavirus positive tests. So incidence rate ratio, relative change in percent positivity, and relative change in percent change in number of rotavirus positive tests. These were the metrics they used. So more than half of the estimate used hospitalization due to rotavirus gastroenteritis as the outcome. And in that, 70% of incidence rate ratio, 68% change in percent positivity, and 83% of relative percent change in absolute rotavirus positive test with specific ICD code. The children less than 5 years old, in this group, 62% incidence rate ratio, 72% of relative percent change in percent rotavirus positivity, and 61% of relative percent change in absolute rotavirus positive test. There were considerable variability in metric outcome age grouping used to evaluate indirect protection. So there were 52 estimates among the adult 18 to 64 years of age, older adult more than 65 years, and 42% were from administrative databases, 31% from laboratory surveillance, 21% from nationally viable case-based surveillance. There were no active surveillance studies. Indirect protection estimate among the adult population. Most estimate from very early post-induced period and 35% estimate from the studies that collected data seasonally. There were very few 6% estimate 5 or more years after vaccination introduced. So indirect protection estimate summary. For hospitalization due to rotavirus gastroenteritis among unvaccinated children under 5 years of old, incidence rate ratio was 60%. The change in percent positivity was 25%, and change in absolute rotavirus positive test with a specific ICD code was 42%. Stratified by under 5 mortality strata, the median incidence rate ratio hospitalized under 5 years old was 60%, 56% among the 3 median mortality countries, and 83 among the 2 high mortality countries. So incidence rate ratio is higher in high mortality countries. So this picture shows that the distribution of 3 metrics, that is indirect protection of rotavirus vaccine, that is incidence rate ratio of rotavirus hospitalization. That comes number of study 110. It comes about 60%. The relative percent change in percent positivity rotavirus among the hospitalization, the total number of estimate was 49, and it comes around 25%. And relative percent change in absolute number of rotavirus positive tests that with specific ICD, the total number of estimate was 40 among the hospitalized children, and that comes into 42%. So indirect protection estimate summarized. For hospitalization due to rotavirus gastroenteritis, unvaccinated children, 5 years, that is incidence rate ratio 60, change in percent positivity was 25, and change in absolute rotavirus positive test was 42. So in this picture, we can see that the in hospitalization group, the incidence ratio is highest in first one, that is 60%. And there is a change in percent positivity, that is 25%, and that is in absolute rotavirus positive test was 42%. And in another study, this is divided into the country with child mortality strata. That is, in first group, the low mortality countries, they found that median ratio was 60%. And in a median country, it was found, incidence rate was found about 56%. And in high mortality strata countries, they found that ICC rate, incidence rate ratio was 83%. So distribution of indirect protection, incidence rate ratio of rotavirus hospitalization among the unvaccinated children under 5 years of age, stratified by country level child mortality strata from studies published between 2009 to 2022. So discussion. The rotavirus vaccine indirect protection may contribute to decline in rotavirus disease among the population where the vaccine is available, including non-vaccinated groups, especially under 5 years. Meaningfully synthesizing the full spectrum of literature and comparing the result was challenging because of variety of method used. The finding of median incidence rate ratio of 60% for rotavirus hospitalization among the unvaccinated children under 5 years of age is consistent with prior systematic review. There were so many studies, and they compared it with previous studies, and it is found that the finding is consistent. So, strength of the study, these estimates of indirect protection were based on relative reduction. Thus, high mortality setting may still see a large absolute reduction among the unvaccinated individuals due to a higher rotavirus burden. This review also includes the estimates of indirect protection among the older children and adults. There were few studies among the children more than 5 years compared to children less than 5 years, and estimate among the individual more than 5 years also showed a consistent evidence of indirect protection. Another strength of studies, some studies among the adults and older found evidence of indirect protection. There were similar number of studies that found no protection or evidence of increased burden of rotavirus directly due to rotavirus vaccination. In the post-vaccination era, there may have been an increased awareness of rotavirus and thus increased testing in adult population, potentially biased result, because the absolute number of hospitalized adults were typically very small. Thus, the robust comparison may be limited, and because of the small sample size in population. The evidence of indirect protection among the adult population remains inconsistent. So, limitation of the studies. These reviews has several limitations. It serves as a broad overview that compares all estimates, regardless of study duration, sampling methods, diagnostics, and severity. To summarize the finding, they made several generalizations when value overlap multiple age groups, post-vaccine year, or outcome. They performed the descriptive analysis based on most frequently reported parameters from literature, including the age, outcome, country childhood mortality, strata, and number of post-introduction of vaccines. So, something about impact factor. As initially I have told that this journal has got impact factor of 5.5. So, these are the factors which vaccine coverage, vaccine efficacy, rotavirus strain circulation, so social and economic factors, and transmission dynamics. These are the factors they decide the impact factor, immunological factor. Then in an impact factor of is 5.5 combined with Q1 considering the top quartile rank indicates that the journal is in a top quartile, that is 25% of journal within its specific field. So in conclusion, this finding demonstrates the need to standardize measurement of indirect protection from rotavirus vaccine. Factors such as age, outcome measured, matrix use, vaccine coverage in population, and rotavirus identification method and year post-vaccine introductions. So, and should all be considered when developing new studies. The additional evaluation of indirect protection in medium and high childhood mortality setting are needed to be better understand rotavirus vaccine performance in the setting. So, rotavirus vaccine remain an effective tool in reducing the disease burden and may benefit some non-targeted group as shown in this review. Thank you very much.
Thank you, Dr. Wankhede, for a comprehensive, elaborative overview of this extensive article. Now, may I invite Dr. Sagar Kulkarni, our ACVIP guidebook expert, for these comments on this article particularly.
Thank you, madam, for the opportunity given. And first of all, I would like to congratulate Dr. Pramod Wankhede sir for such an excellent presentation of the article. So before I comment on the article itself, let us do some basic discussion about some points which were always there in this article. And we have to understand that there is a difference between efficacy and effectiveness. What is efficacy? It is the percentage reduction of a disease in a vaccinated group of people compared to the unvaccinated group. So this is basically the ability of a vaccine to protect an individual under ideal conditions, like example, what we calculate in clinical trials. But are we calculating efficacy in this article? The answer is no. What we are calculating is effectiveness. And what exactly is effectiveness? vaccine effectiveness is a combination of three things. First is vaccine efficacy, coverage, and herd effect. So in this case, what we are trying to quantify is the herd effect, and that is what we are going to see. Now, two terminologies which I could understand are conflicting is one is herd immunity and one is herd effect. So there are many people who use these two terms interchangeably, but actually they are different terms. I'll tell you. Don't confuse between immunity and herd effect. So what is immunity? Herd immunity is the proportion immune in a herd. So it will be basically a plus of those protected by vaccine and those which are protected by natural infection. Now, herd immunity is applicable to any infection, isn't it? So it is irrespective of its transmission pathways. Okay, but herd effect, it is different. It is incidence reduction of a disease among non-vaccinated members when a good proportion is vaccinated. Now, this is seen only in cases where humans are the source. So here the route by which the spread or the transmission occurs is actually dealt with. For example, let us say pneumococcal vaccine. Now we know that pneumococcal vaccine affects the nasopharyngeal carriage and thereby prevents the transmission, and then thereby we get a herd effect not only in other unvaccinated individuals, but let us say in elderly also or neonates of non-vaccinating age also. That is called as herd effect. An example of herd immunity was, let us see, in COVID. Now, in COVID, we know that the vaccines did not give protection against infection, but it just gave protection against disease. But still, herd immunity actually worked that time. So that is the difference, basic difference between herd immunity and herd effect. So what are we calculating here in this article is basically herd effect. And when we always speak of the term indirect protection, I'll divide it again into three different parts. Let me tell you. Now, you know, in old times when polio was given, they used to say that when we give polio drops, then that polio virus used to excrete in the stools, then it used to contaminate the sewers, again there will be contamination of water, and again food articles, and the person who will eat that will again get a active immunity. Now this is quite absurd, someone eating stools of someone else and getting immunity. So really we do want such type of immunity? No, we don't want. So if indirect immunity is being achieved by such a thing, we don't want it. If such a thing is occurring, we have to focus on giving more potable bacteriological and virological treated water, and we don't want such type of immunity. And even this hypothesis has been nullified now. No one accepts this hypothesis. So another type of indirect protection is those in unvaccinated individuals who are age eligible. So they are age eligible, but they are not taking vaccine, but they are deriving their benefit from those who have actually taken vaccine. Do actually we want this thing? Actually, no, because what we want that individual should also take vaccine, but should not derive the benefit from those who are actually taking vaccine. Now, we accept that we are getting some such indirect protection and we are happy about it, but actually we want to increase the coverage so that we don't leave much of the population unvaccinated. Now, there is the third subset. A third subset is those individuals who are age ineligible for vaccination. Let us say I want to give rotavirus vaccine to a 3-year child or 4-year child. Can I give? I cannot give it. There is no DCGI approval. Can I give it to older children, adults? I cannot give it. But if I am getting indirect protection to these individuals, that is the most desired part. If I get such an indirect protection, that will be a boon to my vaccine. It will increase indirect protection. And as we have seen in the definition of effectiveness, then that will increase the overall effectiveness of the vaccine. So this is definitely what is desired. Now, sir has very beautifully presented the whole article and told many fallacies when he was presenting. But to point out some more fallacies in a short nutshell, only the hospitalization was taken as outcome in 73% of studies. But nowhere it was mentioned what was the criteria of hospitalization. Never I have heard the term Vesicaris scoring system in this whole article, by which they measure the severity of gastroenteritis, whether it is mild, severe, very severe. I have not seen in the whole article whether they measured the effectiveness against misuse of antibiotics, whether they measured the effectiveness against OPD visits or days lost or morbidity, etc. It was not measured. So this was a major fallacy. Now, hospitalization criteria is very different in private hospitals and government hospitals. We all know that. Now, we know that particularly in our settings like India, 80% of the OPD and IPD is being catered by private hospitals. So have these studies taken into account these IPD cases? Was a data available? Is there a very good compilation of data from private setups in India? I really doubt it. Number three is, what do they really mean by vaccinated? Had they ever tested for rotavirus specific IgA or serum rotavirus IgG? Because vaccination does not mean the child was protected. So how did they really differentiate these two categories? Because we know that the efficacy of vaccine is hardly 50% in Indian population. That was one more fallacy. So they did not measure that immune status. One more thing is that more studies are required for understanding rotavirus epidemiology in post-vaccination era, especially with different performance of different vaccines and introduction of newer vaccines. So with introduction of newer vaccines, the overall epidemiology changes, and more studies are important when we understand what is the exact dynamics which are taking place over a period of time, even in those countries where this rotavirus vaccine was started. One major fallacy which I noted in this study was that only 7% of studies were from Asian countries and only 11% were from African countries. Now, how are you supposed to compare when most of the studies are from European and USA background where the efficacy is more than 90%, the coverage is more than 90%. So how can we compare the indirect protection in those countries from our countries is a very difficult task. But of course, the author has thought of it. That is a very good part. One more point is that vaccine introduction has been started in many countries very recently. In India also it started very recently, but we as private practitioners, we are giving these vaccines in many years, since 10 years. This article take into consideration the vaccination which was done in private hospitals and clinic, even in HMIC countries also. No, they have not taken into consideration. One more point is, have they considered indirect protection against vaccine serotype versus indirect protection against other multiple prevailing strains? Because we know that in countries like India, there are multiple prevailing strains which are there in India. So how are they measuring indirect protection against the serotype which is there in vaccine versus the serotype which is not there in vaccine? That thing has been mentioned in this article. So yes, there was a lot of heterogeneity in the study design and data quality. But of course, there were some good points that they considered at least 2,000 articles from which they selected the articles. Congrats to the authors that they have done such a study, because we know that cost effectiveness by public health will take into consideration the herd effect and herd immunity, whether we want it or we don't want it. And we do agree that some indirect protection plays a role. Vaccine effectiveness also can improve because of indirect protection. But since measurement of indirect protection is difficult, it actual inclusion in vaccine effectiveness and cost effectiveness is difficult. So to in nutshell, more studies and analysis are needed in future to quantify the indirect protection so that it will help in decision making. But overall, a good effort in the article. That is what I want to say as an expert.
Thank you.
I would like to tell one thing. The characteristics and method they have used in this article of study, that can be useful for evaluation in future.
Agreed.
Yes, thank you. Thank you, Dr. Wankhede. And thank you, Dr. Sagar, for being so critical about your view for this article. Both have done really very nice job. And now we just have seen that immunization is one of the most cost-effective public health intervention to reduce the mortality. And here we integrate other preventive health services from the government also, and iron is most important of that. Let us know it from our second speaker, Dr. Mamta Khandale. Over to you, Dr. Mamta, for your presentation.
Yes, ma'am.
Sure.
Is it visible, ma'am?
Yeah.
Good evening, everyone. First of all, myself, Dr. Mamta Khandale. First of all, I want to say thanks to Maha-IP with Raigad IIP for giving me opportunity for speaking on this platform. So today I'm going to present a research article, Need to Go Beyond Iron Supplementation for Anemia Mukt Bharat among children under 19 years, an ecological study. So before going to the actual article, we would see the silent features of Anemia Mukta Bharat. Anemia Mukta Bharat is intensified Iron Plus initiative aims to strengthen the existing mechanism and foster newer strategy for tackling anemia. It focuses on 6 target beneficiaries group, 6 intervention and 6 institutional mechanism to achieve the future goals of Poshan Abhiyan. 6 beneficiary groups are children's 6 to 59 months, children's 5 to 9 years, adolescents 10 to 19 years, pregnant women, lactating women, women of reproductive age group 15 to 49 years. 6 interventions are prophylactic iron folic acid supplementation, periodic deworming, intensified year-round behavior change communication campaign, testing and treatment of anemia using digital methods, mandatory provision of iron and folic acid fortified foods in government-funded health programs, and intensifying awareness, screening, and treatment of non-nutritional causes of anemia. 6 institutional mechanisms are intra-ministerial coordination, National Anemia Mukt Bharat Unit, National Center of Excellence and Advanced Research on Anemia Control, conversions with other ministries, strengthening supply chain and logistic, Anemia Mukt Bharat dashboard and digital portal, one-stop shop for anemia. So coming to the article, need to go beyond iron supplementation for Anemia Mukt Bharat among children under 19. This article is taken from journal Preventive Medicine Research and Reviews, published in 2024. And the authors for this article are Dr. Arvinda Chinnadurai and Dr. Sangeeta Raja from Department of Community Medicine, Tanjavur Medical College, Tanjavur, and Department of Ophthalmology, Arvinda Eye Hospital, Madurai. Introduction. As we all know, anemia is a prevalent issue in India, especially among reproductive age group. Anemia is designated by WHO into 4 categories based on prevalence ranging from no public health problem, less than 5%, mild from 5% to 19%, moderate from 20% to 39%, and severe more than 40%. This is significant concern in India across different age groups. And recent data from National Family Health Survey 4 and 5 indicates prevalence of anemia exceeds 60% in under 19 years age group, especially among females. And as we all know, the most common cause of anemia is iron deficiency. So leading to implementation of iron supplementation programs like National Iron Plus Initiative and Poshan Abhiyan. Poshan Abhiyan aims to reduce anemia prevalence by 3% annually. But despite of these efforts, prevalence has increased from 53% to 60%, raising concern about effectiveness of existing program. Anemia prevalence is an important indicator of social progress impacting inequality, labor force efficiency, and employability of skilled individuals. So Government of India launched Anemia Mukt Bharat scheme to combat anemia. Nutritional anemia involves different deficiencies of micronutrients like iron, vitamin B12, vitamin A, vitamin D, and zinc. Objectives. The aim of study is to evaluate the impact of micronutrient deficiencies on anemia prevalence across various states and to assess the contribution of existing initiative under Anemia Mukt Bharat under children of 19 years. Material and methods. The study is an ecological study that analyzes the population level data on anemia prevalence and associated micronutrient deficiency from nationally representative sample across India's states and union territories. ethical approval is not applicable since the data set were available in publicly available portal. The data sources are National Data Analytic Platform. This platform provides primary data set for study. Comprehensive National Nutritional Survey. This survey provides data on anthropometry and micronutrient deficiency. Niti Aayog Sustainable Developmental Goal Index. This data used for to correlate socioeconomic causes with anemia. Then anemia, a health management information system and Anemia Mukt Bharat website. These sources were used to gather data for Iron Plus initiative. Data analysis was based on Niti Aayog categorization of state, recently published in Niti Aayog Health Index. SPSS software version 28.0 and Microsoft Excel 365. These tools were used for data analysis. Results. The states are classified according to Niti Aayog classification of states and recently published in Health Index 2020. The states are classified into big states like Uttar Pradesh, Assam, Telangana, small states like Nagaland, Arunachal Pradesh, union territories like Delhi, Pondicherry, and Lakshadweep. The data for Nagaland and Nagaland, Pondicherry, Ladakh, Andaman, Nicobar Islands, Lakshadweep, Dadar, Nagar Haveli were unavailable for analysis. The overall prevalence of anemia was based on age categorization, gender-specific prevalence, and burden of other micronutrient deficiencies was presented as mean. Weekly iron and folic acid tablet intake and albendazole intake in schools and Anganwadi among children were taken as key indicator for Anemia Mukt Bharat dashboard as surrogate marker to assess the coverage of existing iron supplementation program. This table summarizes the state where the prevalence of anemia and serum ferritin deficiency is greater than their counterpart. Low serum ferritin level is an early and specific indicator of iron deficiency anemia. In cycle of iron deficiency anemia, the decrease in serum ferritin level precedes the hemoglobin level. So there could be two possible scenarios. In first case, the serum ferritin prevalence is higher than the prevalence of anemia. It would imply iron deficiency could be the most common cause of anemia. And the study findings suggest that out of 30 states, 13 states were reported in this category. In second scenario, if the prevalence of anemia is higher than the prevalence of serum ferritin deficiency, then it would imply the most common cause of anemia could be due to other micronutrient deficiencies like vitamin A, B12, and vitamin D, in addition to iron deficiency. So in this table, we could identify as 17 states with lower serum ferritin prevalence, implying micronutrient deficiencies other than iron could be the predominant cause of anemia in these areas. This graph is showing prevalence of anemia and micronutrient deficiencies among the states and union territories in 5 to 9 years of age children. This blue bar is showing prevalence of anemia in big states. Then this orange bar is showing prevalence of anemia in small states, and gray bar is showing prevalence in union territories. Which is the prevalence of anemia in both small states, big states, and union territories is approximately equal. And other graphs is showing prevalence of serum ferritin level, then prevalence of folate deficiency, which is very high in both big states and small states. Then prevalence of vitamin B12 deficiency, prevalence of vitamin D deficiency, prevalence of vitamin A deficiency, and prevalence of vitamin of zinc deficiency. This graph is showing anemia, prevalence of anemia based on sorry. This graph is showing prevalence of anemia and micronutrient deficiency among the state and union territories in 10 to 19 years of age. And as comparison to with 5 to 9 years, the anemia prevalence is higher in 10 to 19 years of age, as well as micronutrient deficiency is also comparatively high in 10 to 19 years of age. This graph is showing prevalence of anemia based on gender in different age groups. Prevalence of anemia in all three age groups, 1 to 4 years, 5 to 9 years, and 10 to 19 years, shows rate ranging from 19% to 42%, and shows tendency of moving towards severe public health problem from current levels. As we see here, the prevalence is more in 1 to 4 years in both groups, in males and female. While in adolescents female group, the prevalence of anemia is higher than the adolescents male group. This graph is showing prevalence of anemia and coverage of Anemia Mukt Bharat in 5 to 9 years of age. This blue line is showing prevalence of anemia. Then orange line is showing percentage provided for iron and folic acid tablet in school, which is good in some states like Andhra Pradesh, Assam, Gujarat, Maharashtra, then Punjab and Sikkim. Then the coverage is some coverage is there or very low coverage is there in some states. And this gray line is showing percentage of coverage of albendazole tablets in school, which we are seeing it is very low in all the states. This graph is showing prevalence of anemia and coverage of Anemia Mukt Bharat in 10 to 19 years of age. Again, here the percentage of coverage of iron and folic acid tablet is good in some states like Andhra Pradesh, Gujarat, Madhya Pradesh, Punjab, and Sikkim. But some states is having very low coverage. And similarly, albendazole coverage in schools and out of the schools in this group is very, very low. So there is strong correlation between anemia prevalence and coverage of iron and folic acid and albendazole tablets. And states where the anemia prevalence is higher tends to have lower coverage. The prevalence of anemia is higher in female and coverage of iron and folic acid consumption is very low, 0.5 to 25% in the survey. And the data from national study shows the lower percentage of coverage could be due to non-availability of drugs on time, irregularity of submission of reports regarding the consumption, and lack of knowledge regarding the importance of consumption of medicines among the beneficiaries. Discussion. Anemia is highly prevalent among children, ranging from 19% to 42%. And the results suggest that while iron deficiency remains a single important micronutrient, other micronutrients such as vitamin A, vitamin B12, D, folate, and zinc also plays important role in prevalence of anemia. As we all know, vitamin B12 causes pernicious anemia, which cannot be corrected by iron supplementation. Similarly, zinc, folate, vitamin D, vitamin A also causes anemia in their mechanism. And hence, even if we improve or strengthen the iron supplementation to a desirable level, the prevalence of anemia is unlikely to reduce unless other micronutrients are supplemented. The gender disparity, there is prevalence is more in adolescents female, 17 to 23% higher than the male. Iron supplementation and coverage. Iron supplementation coverage in school and Anganwadi is dismally low, 0.5 to 25%, contributing to high prevalence of anemia. The consumption of weekly iron and folic acid tablet is low, indicating need for improved implementation and awareness. And this could explain the reason behind the increase in prevalence of anemia in latest round of NFHS 5. Impact of anemia. Anemia can negatively impact child's growth, development, and cognitive ability. And economic implications. High level of anemia threatens productivity and economic security. This problem is complicated in India because India also reports gross macronutrient deficiency and obesity. Hence, we need fresh outlook and re-examine the nutritional priority of India. Recommendations. Policymaker should focus on integrated strategy, including nutritional supplementation, healthy diet adequacy, and program convergence. Supplementation of non-iron nutrients in addition to iron is necessary to address anemia. Effective implementation of iron supplementation programs in Anganwadi and schools with focus on especially on adolescents female group. Food fortification can help combat anemia. Study limitations. This study is limited by data availability of children of less than 19 years. Ecological fallacy. The use of population level data has introduced the ecological fallacy. Then missing data may have impact on analysis. Then the study could not explore interstate and intrastate variation due to unavailable data at district level. Conclusion, anemia is a serious health problem among children under 19, and it needs a multifaceted approach. Supplementation of vitamin B12, vitamin A, and vitamin D. Enhancing the reach of weekly iron and folic acid and albendazole tablet, educating about their benefits and gender-specific causes can help lower the anemia rates. And finally, an in-depth examination of current obstacle in Anemia Mukt Bharat program can improve its coverage. Relevance to preventive medicine. The study addresses a critical public health issue by evaluating the role of various micronutrient deficiencies in anemia prevalence among children, highlighting the need for multifaceted approach in preventing strategy. Implication for clinical practice. The findings suggest that iron supplementation alone is insufficient to combat anemia effectively. Incorporating multiple micronutrient supplements in clinical practice could significantly improve treatment outcome in affected population. Strength of journal. The study provides comprehensive analysis of anemia prevalence and associated micronutrient deficiency among children in India. Then use of nationally representative data allows for broader understanding of issue, and the study highlights the importance of addressing deficiency in micronutrients like iron and also vitamin A, B12, D, zinc, and folate. The finding provide valuable insight for policymaker to improve anemia prevention and treatment strategies. The weakness of research article is the analysis is ecological, as it is ecological study, the analysis is based on population level data and limiting the ability to draw conclusion about individual level factor. The study was limited by availability of data for under 19 children and lack of availability of data of district level. And missing data for certain states and region may affect the analysis. While the study focuses on only 6 micronutrients, other factors like malnutrition, infection, and socioeconomic condition may also contribute to anemia. These are some consequences of selected micronutrient deficiency. Iron deficiency will cause limited iron availability for RBC production, subsequent reduced hemoglobin production, and oxygen transport. Vitamin B12 and folate deficiency will cause ineffective DNA synthesis and subsequent altered RBC formation. Vitamin A deficiency will cause impaired iron absorption and utilization. Zinc deficiency will hamper the iron absorption, and vitamin D deficiency will also hampers the iron absorption. So take home message, iron and vitamin B12 are not only the cause of anemia among children under 19, but also micronutrient deficiency causes anemia. Supplementation of multiple micronutrients along with iron is necessary. Thank you.
Thank you, Dr. Mamta. Very nice presentation, and it's a very good and important take-home message as well. Now, may I invite expert Dr. Ajay Keshwani sir for his comments.
Good evening, everyone.
Good evening,
Myself, Dr.
sir.
Ajay Keshwani. Am I audible?
Yes, sir.
Yeah. I am very much thankful, first of all, to Maha IIP, Raigad IIP, Dr. Hemant Gangolia sir, Dr. Ram Gopal Chejada sir, Dr. Amol Pawar, Dr. Chitra Kulkarni ma'am, Dr. Our own Vikas More, and all for inviting us today from all the way from Raigad to the other corner of the Maharashtra, Yavatmal. So, and I'm for congratulate Dr. Mamta Khandale for such a very nice presentation. Even she has discussed everything in detail so nicely. So she hardly kept any scope for me for an expert. Even she has discussed the weak point also. But still, in as an expert, I would like to add, we have to modify this Anemia Mukt Bharat program for a comprehensive approach. Like first is strengthening the primary healthcare. So primary healthcare has to be strengthened in the form of to provide the essential services like anemia screening, diagnosis and treatment at root level. Like we have so many Anganwadi workers, Ashas and all, they are visiting, and the government till now has been concentrating only on the ANC mothers. But as we observe now, the incidence and prevalence of anemia under 19 is very high. So that could be taken care of if the primary healthcare level has to be strengthened. Then second is we have to promote the nutritional education. We have to conduct the awareness campaign to promote the healthy dietary habits, especially among the women and children, like iron-rich food, as she also mentioned about the iron-fortified food. And there are so many common and cheaper products, like a jaggery. So in villages, they are they have to be promoted like a chikki and ladus and all for this. And third is we have to improve the sanitation and hygiene. As improvement, we have to implement the program to improve the sanitation and hygiene, and we have to promote the hand washing practices and provide the clean water, particularly in the rural areas. Then fourth is we have to address the underlying health conditions. Like we have to screen and treat the underlying health condition that contributes to anemia, like hookworm infestation, malaria, any chronic illnesses. As Dr. Mohanty sir day before yesterday had a discussion when he has been in military hospital, the only investigation they advise for anemia is stool routine microscopy. That was almost 6 decades back. In 60s, 70s, the incidence of hookworm infestation, that itself is a primary cause of anemia, which has to be taken care of. Like nowadays, children are also more from junk food and all, so that we need to be taken care of the underlying illnesses. And other like even chronic malaria is nowadays is rare, but we have to be think about the other underlying illnesses. Then we have to strengthen the surveillance. We have to establish the robust surveillance system to monitor the anemia prevalence, like identify at-risk population and evaluate the effectiveness of interventions. So surveillance should be very much like implemented very much like strictly. Then last is we have to engage with the communities, which is very important. we have to involve the communities in the planning and implementing intervention to ensure local ownership and sustainability. So all these communities, we have to involve them, and like we have many places there are meeting and all with these ASHA worker and this. So they should go to the community. They should explain them everything in detail and all these about the complication of anemia and prevention, which is not very difficult, I suppose. That's it from my side.
Yeah, thank you, sir. Thank you very much. Really, both of you have covered everything. Now, the thing is that we are getting very good amount of questions and some experts also to have their comments. Pallavi ma'am, any questions in the chat box on YouTube?
No, ma'am.
Okay. Dr. Jay, could you see? You want to ask something? Dr. Jay Bhandarkar is our, you can say, brainchild of this journal journey was from Dr. Hemant Gangolia sir and Dr. Jay Bhandarkar. Now, may I request Minash Sheikh sir to have his comments? Dr.
Thank you,
Minash?
madam.
Yeah.
Yeah, good. Am I audible?
Yes.
Thank you, madam, for giving me this opportunity. At the outset, let me congratulate both the presenter, Dr. Pramod Wankhede, sir, who happens to be my senior at IGMC Nagpur, and Dr. Mamta, madam. This reflects the level of J&J, which has grown up significantly. I must say, both the articles were not easy. Very difficult to analyze, understand, and express, which both of them have done very well. So also our experts, I was listening to Sagar, and every time you listen to Sagar, you learn something more. So that's the beauty of Sagar. He's doing excellent. So also my friend, I'm Ajay. My only question to Mamta, Dr. Mamta, this article belongs to which journal and what age? Probably I missed that particular part.
Sir, this article is from Journal of Preventive Medicine Research and Reviews, published in 2024. And the authors are Dr. Arvinda Chinnadurai and
Yeah, there were two South Indian Tanjavur Medical. That I learned.
Tanjavur Medical
So
College.
why I'm asking, because if you see this article is actual eye opener. So NFHS 5 came in 2021. And there was a lot of hue and cry with regard to expression of iron deficiency anemia over there. Because there were a good number of iron deficiency anemia which was actually reported in that particular, but then after that, this particular paper, which is actually has shown so many things. So this article is really impressive and eye-opener, and I must compliment and congratulate Pramod sir, because I was more focused on this. I mean, it came a little later. I'm talking about the second article. They did very well. Dr. Mamta expressed very well. Congratulations and compliment, and to the entire team. Doing excellent. Thank you.
Thank you.
Thank you, sir. My question to Dr. Sagar is that how to tackle this anti-vaccine lobby in our country? Means the intentions are good, the Niti Aayog is doing everything, we are trying very hard for the maximum coverage, but there are hurdles. Your comments on this?
So anti-vaxxers are there everywhere, and the more educated the population, I think even the anti-vaxxers are more, I'll tell you. So it is not that anti-vaxxers are there in India and they are not there in Western countries. They are there also. So how to tackle is the question. First of all, you have to understand what exactly is in their mind. Sometimes I do really go through the videos which are being posted by anti-vaxxers just to understand what are the points they are raising so that I can counter them. So recently, like we had some video about HPV, and what all things she said was absolutely absurd. But what absurd they are saying, I have to listen to that so that I can express what exactly she was not supposed to say. I was going through one very beautiful article. They said that how is this anti-vaxxer propaganda spreading? So suppose they are using social media, then let us also use social media to counter them. If they are using Instagram, let us also use Instagram. If they are using articles with all fake narratives, let us produce some counter articles to counter them. You can use all the artificial intelligence, you can use mass media, you can use televisions, you can use newspaper. So first you understand what is spreading, and then you use all this every modern technology at our disposal to counteract that. That is what is my opinion in recent times. Because otherwise all our government functionaries, government officers, asha workers, anganwadi workers, they are doing their job amongst the far outreach or the less educated people. But the anti-vaxxers, I'll tell you, are actually educated people who are spreading lots of things. And to counter, I think these things has to be done. That is my opinion in today's world.
Yes, in our camps, we have seen ourselves that even in the school children, they are getting weekly iron supplements in after their midday meal, and it's very well implemented. My question to Dr. Mamta is, what are the natural sources of these various micronutrients which you have just elaborated? And here I want to highlight the point of bioavailability of natural foods as well, and as comparison to that, our drugs. Your comments.
Ma'am, we could, for iron, we can advise jaggery, which is most important. Then we can ask the mother to cook the food in iron utensils. Then like a beetroot, green leafy vegetables. These are sources of iron. Then some sources of vitamin. The vitamin B12 sources are like
Sprouts.
sprouts, like.
Yeah.
Yes.
Our
Non-veg
mentor,
also-
Dr.
Sir,
Mohanty sir
carrots,
is there.
Sweet
Non-veg also
products.
can,
Yes,
if,
sir.
if parents are affording or they are non-vegetarian, then we ask them to have a red meat, which
Yes.
also have this to have a strong source. Then
Yes.
even like we said that's whey and rice, they should not be this, and like a green leafy vegetable and all. And for vitamin A, we can again a fish liver or this, and then vitamin D also. So these are the some common things which can for ask them to have a sunlight exposure for vitamin D, and all we can have a this protein rich diet also.
Yes, sir. Most important. May I request our mentor, Dr. Mohanty sir, to have his comments?
I'm very happy and really delighted today. While selecting these papers, I was skeptical whether these social pediatrics papers will be liked by our friends or not. But it seems that this is they have realized this has got many application oriented values to implement in our community. First of all, one clarification about the rotavirus vaccines. Vaccines, they give cross protection. What is the type of rotavirus? Is immaterial. Recent studies have shown that any type of rotavirus vaccine gives a cross protection to other strains also. So that's why this study was, they're not taken care of for this vaccine type and strains prevalent there. Secondly, this is 16-year-old through study and taking some data only. It's not a prospective study. So that limitations will be there. But it gives a overall view to us that such a gigantic operation could be done, and some beautiful results have come. About Mamta's paper, this is a day-to-day affair from your student days. We also keep on learning कि क्या खाने से खून बनता है. So even school में लोग जानते हैं. But we are not enforcing this thing at home. Moringa is a jewel in our community. Moringa leaves are full of iron. this spinac is good iron source. So these natural sources, as rightly pointed out by the expert, that should be highlighted. Although this paper has not done it, this is a Niti Aayog hi-fi funda, but these things should have come. What are the natural sources? Like you said, jaggery. Jaggery, we were taking jaggery in the rural areas. We're not using sugar. We're using jaggery. And while cooking that jaggery in a iron pot, the iron gets into this jaggery. And most of the pots were also kadai of iron. So sabji, dal, jo bhi banta tha, it was getting some iron tinge into it. And if you see the latest issue of Nelson, they do not highlight the administration of B12 or vitamin D or C, whatever it is, separately. They emphasize if you are taking care of the balanced diet, in the diet itself, the natural sources, everything will be automatically reaching the patient or the individual. Focus on the iron supplements. Because if you focus other so many things, the proper focus gets out of the focus. So let us focus on the iron supplementation. That is more important. And so this it is fortifying iron. The rice and other food substances is a really difficult task. But if you we give iron supplementation in our daily diet, give a good education awareness in the schools, in the curriculum it has come, but it is not going to the application level. That is you engage. I think you should engage the school teachers, Anganwadi workers. They are the friend, philosopher, guide. I think they can do a better job all over the country. Thank you.
Yeah, thank you, sir. Dr. Hemant Gangolia, please.
Probably two questions to Dr. Mamta, madam. In any of the national programs, because you spoke about all micronutrients, so whether supplementation is done of micronutrients and in what formulations? If done, what formulation, and how it is monitored, for how many period, how many duration it is, how much duration is given. And the second question is that really, if you want to supplement micronutrients, how to do it that? That is one question. Second, in case of vegetarians, how do you make, what are the sources that you can give for the B12 as well as vitamin A?
Sir, for nutrients for vegetarian diet, they should go for green more greeny leafy vegetables. Then dairy products may be provided like cheese, then milk. They will provide vitamin D. And good exposure to the sunlight, which also will be provided vitamin D. Then fish, carrot. Sorry, not
Yes,
for
correct. You are correct. You are correct.
For
Carrot,
vegetarian diet.
Yeah. Carrot and beetroot. For
Carrot
vitamin
and
A.
beetroot. Carrot is rich in vitamin A. Then beetroot is rich in vitamin in iron. Then many other fruits are rich in vitamins.
Why to forget our millets?
Yes.
So Madam Chitra, madam, if you permit, I can answer this. I will
Yes.
try to answer this.
Yes, sure.
So Hemant sir, your question is not that easy to answer. I must, it's easier said than done at the national program level, because programs have their own logistic nowadays with so many things, including veg and non-veg and all those things. So this context, having a comprehensive
Minaz, your voice is breaking. Can you close your video and speak? Your voice is breaking. Yes.
Okay, done. Now
Yes,
it is clear.
Yes,
Yeah.
yes.
So
Yes, go
see,
ahead. Go ahead.
so having a RTU, a desired RTU containing everything, micronutrients, irons, and everything which is required in a therapeutic or a prophylactic level is a real challenge for the country like ours, which contains the almost 1/5 population of the world. Having said that, I think our country and our ministry is doing great with regard to variable RTUs that are available. So at individual level, it is easier. But at the national level, having all the micronutrients in one recipe for a variable population is a real challenge. So I think we have to accept that challenge, and let us accept that the government is doing their best at state level or central level to address this issue as possible. I think that is the answer which we can make out from all of us.
Sir, the
Will you-
second question
Yeah,
was
Meenakshi, can I
how to monitor? Yes, sir.
Ma'am, please, just a moment for the Gangolia, sir. Sir,
Yes.
for a malnutrition children, it's available packages like F40, F75. Okay, but this study is for under 19, till 19 years of age. That's what, and this program is recently introduced, Anemia Book Bharat. If I think, but sir has asked very genuine and a good question for future. Like for Anganwadi worker and all, they are promoting. But if like they can directly give the, as Mina sir has told, RTU, so that is also a good in future. But for pediatric age group, it is available.
But Ajay, that available is for a particular set of malnutrition. Here we are talking about a specific. See, we cannot have all kinds of nutrient in a prescribed dose for a large population.
Yes,
It's not easy. It's
And
not
that
easy.
too, sir, you said na under 19 is 20%. I think it is more than 20%.
Exactly.
I think the population is more than 20%.
Exactly.
Under
So
19,
So if our under 35 population is 1/3 of the overall India population,
Yes, of
so
course,
under 19 will be almost 25%.
Yes,
So
sure.
addressing that issue is a real challenge.
100%.
But still, I believe our government is doing and trying their best, and we are better than in the past.
Yes.
And with regard to next question with regard to the monitoring. See, monitoring in our home is difficult. So monitoring at the national level, you can imagine how it is difficult.
And that too
However,
by Anganwadi worker and all. I am telling you nowadays, see, they have a heavy burden of antenatal mothers.
Yes.
In spite of that, they are taking reasonable. Mina sir, have you heard the incidence of prematurity? RDS was so high 5 years, 10 years back in our setups, like here. Particularly for the crop season now. If there is a rainy, they go for the work. They don't bother about twin pregnancy. They don't bother about anemia. They just go for work for their
livelihood,
earning. Yeah. So that's what we are saying. They are more often at monitoring at root level is primarily Anganwadi worker, Asha worker. They are for the antenatal mothers. But here it is good under 19. But that will take time. But I think it's a good initiative.
The question why I asked is because we used to give vitamin A in our peripheral setting of practice. Nowadays we don't give vitamin A, not too much, as well as you said a zinc. Zinc we do supplement, but the point of this there, while we are supplementing with zinc, vitamin A, B12, folate, how do you monitor? Because we don't do these levels at our level.
I agree with you. I agree with you.
Then how do and what is there any study or is there any protocol we say okay, we can give for this much duration, it probably will not cause the side effects of the excessive dose of these micronutrients. Therefore I asked these questions, and I do not know whether Dr. Ajay Keshwani sir has deliberately closed the video because we are not seeing it, sir. We would
No, sir. No.
We would
He
like
must be traveling.
No, sir. I was not aware, sir. I was. He is asking me, please allow Zoom workplace to access your camera from the device setting.
Okay. No,
It's my privilege.
Dr. Vikas More wants to
So there is a
answer.
sir,
Yeah.
no, there is a sir, probably there is a
Sir,
technical glitch at the end of Ajay Keshwani sir, because we wanted to see the sir of Dr. Vikas More as well. We met at Yavatmal, but last sentence, because I remember distinctly Dr. Hemant Joshi sir saying always, कि whenever you at any time of this at the periphery, you give the gift of iron kadai to every home. And we
Yes.
should
Yes,
cook,
yes,
and we have
yes.
lost that, and almost as we are going developing, we don't have any iron kadais in our home
Oh,
also.
no, we
Uh,
do have. In periphery, we have.
so probably that should go on rise, and advocacy for iron kadais.
Yeah. Dr. Vikas More wanted to add something. Yes, sir.
Firstly, I just wanted to wish Keshwani sir a very nice good evening for
Good
because
evening,
this is-
dear.
Yeah. So thank you, sir, for being a part of this journey. And one slight correction regarding Dr. Mamta madam, that she told that beetroot is a good source of iron.
Yes.
It has only 0.8 milligram per 100 gram of beet, so it is extremely poor source of iron.
It
Right.
is
Along with
vitamin
the
A.
pomegranate also. So pomegranate and beet are not a good source of iron. That is one correction I wanted to.
Yes. Yeah, it is having vitamin A.
True.
Beetroot
Yes,
is
it is true.
better for vitamin A. Acha, the next month topics are
Madam, may I
yes.
suggest one thing?
Yeah.
Because we have these two excellent articles, probably, and we have good experts. We can have a small table, these sources in case of vegetarians, non-vegetarians, to make some table really with backup studies, because this beetroot I was also going to say, but I didn't wanted to discourage the speaker. Therefore, beetroot is not a good source of iron, 100%.
Yes.
So it happens. I think it happens. We have to accept that. I mean,
Yes.
it is like,
Sir,
it
it
happens
is
to
a
the best of
misnomer
its speaker.
that
Yeah.
it is red and
Yeah.
it is
It's,
having
no, yeah,
iron. It
yeah,
is
yeah.
not
I,
having iron. It
yeah.
is
So-
for vitamin A.
So,
Yeah, yeah.
so probably by having a good table, we can search the literature, but we have so much studied personalities over here. We can have a good table for ourselves at our settings. We can advise to our patients, ye khao, ye khao, ye khao. And one more thing,
You know,
we did one good study of, probably I don't remember the exact measure, but 20 grams of jaggery and 50 grams of groundnuts at our Neral PSC given to the over period of 6 months. It really increased the weight as well as the hemoglobin. That was a study which we did, and we given this study to the. It was done at PSC and was given to the civil surgeon of Alibag also.
I have one suggestion if you agree. We are almost 10 months now. We have 20 journals read. Hemant sir and Mohanty sir, Chitra madam. Can we have a PDF small booklet compilation of this, which can be released in the next Mahapadicon coming 28th?
So it is
It's
a
possible.
task
Just
of
collect
past
the.
Maha-IP president.
Minas, you missed the biggest
Uh.
name to this compilation, Dr. Neha Singh. So she will do it.
Exactly. So I think that's a good idea. Just have in every year, have the previous years and keep on adding the next years. So you have every time there is new book which is coming up, because it will give a glimpse of what actually we have done, and we can go through also.
Yes.
So I think you can, Hemant sir or Neha, you can take up this idea, take all the PPTs and all, whatever in PDF and all, have a format, and have a critical analysis, and just publish and release in the next Mahapadicon coming up. And it is possible. One can do it.
Yeah, thank you.
take-
Thank you very much.
Take up to the president secretary also. Once they agree, I think that's a very good idea.
Yeah, since it has come on this platform, definitely we will have to think about it seriously. And now it is time to declare for the next month topics. It is the current topic of review article on monkeypox. And another will be a original research paper as association of mother's milk and growth among moderately low birth weight, a prospective cohort studies. Soon, within a week, we will select the speakers and then experts. Now, may I request Raigad IIP President Dr. Vikas More to give vote of thanks.
It is an honor, madam. First of all, we are already crossing the time limit, so I will do it quickly. I am very much thankful to Dr. Kulkarni sir, Dr. Respected Keshwani sir, for being expert for this wonderful journey. Dr. Mamta and Dr. Pramod Wankhede sir have done their job perfectly. Ganguly sir has added his wisdom. Mina sir is a pleasant surprise for all of us that he added his wisdom, and he is a big brother of IIP Raigad all the time. He is our troubleshooter many times.
My pleasure. It's my pleasure.
And many special obeisances to our dear Niman Mohanty sir for the kind of stature he has, because he's so simple and so humble that he accepts our delay and whatever. He forgives us all the time, but he is very humble. We are so fortunate to have you, sir. Chitra madam and Neha, you are our asset to IIP Raigad. I am so proud of you both. Especially and Vishal, thank you for his support, and especially Ram Gopal Chajara sir, then Amol Pawar sir, then Satish Sahane sir. They are always behind us. And especially lastly, my heart goes to all delegates who are still present at 10:30. So like encouraging us to
Dr.
go
Vikas,
ahead again.
Dr.
more
Vikas,
and more.
Dr.
Yeah.
Vikas, Pallavi madam, Dr. Anjali madam is there, Dr. Jayashree Deshpande, thanks for
Yeah.
attending this.
Yeah. So Jayashree madam and Anjali madam are always they're like their sister brotherly branches of IIP Raigad, and especially MAHIP, like madam, like technical support is being given by MAHIP.
Pallavi
So,
Dharmadhikari, yes.
Pallavi Dharmadhikari madam. So thank you so much, all of you, for your wonderful participation. Thank you
Can
so
we
much.
stop recording now?
Yeah, we can stop.
Yeah, Chitra madam, this is one